All right, I think we're gonna get started because we have an hour and it's gonna be a full hour, I think, because it's a interesting set of issues we're going to talk about. So I'm going to start to share my screen. For those of you, I'm Jody Platt. I'm faculty in the Department of Learning Health Sciences, and I'm really happy that we're here today. So I'll provide a quick introduction, but the main show today here is to hear from my colleague, Lauren Taylor, who has prepared a really interesting and engaging talk for us. But just to set us up, so this is the Collaboratory, and I think many of you have already been here before and are familiar with the webinar series that they've been doing. Today, we're going to talk about restructuring health systems for learning, building equity into the learning health system. So we're not going to shy away from small problems. The session is just a couple of quick housekeeping items. The session is being recorded. You will receive a link after the session is over. You should be seeing some closed captioning live right now. The Zoom chat will be open for comments. And we also want to hear your Q&A feature throughout the session. So feel free to jump in with those questions and we'll address those later. Again, we've left a lot of time for the question and discussion aspect of this because in some ways that's where some of the most, not the most interesting because Lauren's super interesting, but but many of the, this material gets very exciting when we have an opportunity to talk about it. So please use the Q&A and the chat to sort of engage with the material as it's being presented. Just a quick background. This is the first of several presentations and webinar events that are going to happen over the course of the next academic year, where the Collaboratory is going to focus on many of the issues it's always focused on, but with a special emphasis this year on the ethical, legal, and social implications of learning health systems. And we've looked at some of these issues again over the last many years. And you may recall 2016 to 2019, we had a series of symposia that engaged an entire day or two sometimes just on these issues, of which there are many. Many of those presentations are archived if you feel like there's nothing else left to watch. It's good viewing, and they raise some really interesting questions. And I think, the premise of many of the presentations and the sort of issues in ELSI for learning health systems is that learning health systems really are an opportunity to build better systems. And will we meet this challenge? Some of the exemplary kind of topics and questions that get raised when we're thinking about the ethical, legal, and social implications of learning health systems center around trust, around community engagement, around bias and not recreating or even exacerbating or making even bigger sets of bias into the system. Clearly, anti-racism needs to be a central tenet in whatever it is that we're rebuilding, and ultimately asking the questions that we can then answer and act upon as we create new learning health systems. So without any further introduction, I'm going to go ahead and set up, again, my colleague, Lauren Taylor, who's we've worked quite a bit on the issue of trust in healthcare, and today she's going to talk about something also related to that, but I'll let her introduce her own presentation, but I'll introduce Lauren, who's an assistant professor at the Department of Population Health at NYU, and she studies healthcare through an organizational lens, applying both theoretical frameworks from business ethics and political philosophy to managerial and policy dilemmas. She has a background, she has a PhD from Harvard Business School, a master's from Harvard Divinity, and a master's from the School of Public Health at Yale. So I'm really excited to have him speak today, and we'll turn the presentation over to you. Thank you, Dr. Taylor.
Thank you, Dr. Platt. It's so fun to be here and to be introduced by Jody. Jody is one of my favorite COVID collaborators, who I feel I know incredibly well, and that she knows me incredibly well, because over the 2+ years we've been working together, I got pregnant, I had a baby, now she's watched this baby grow up. And just the other day I was like, wow, it's so weird. I've never met Jody in person. I hope, Jody, can you just confirm you are seeing the slides correctly, so you're not seeing a notes view or anything?
Yes, I can see that it looks great.
Ideal. Okay. So I am setting my timer here for 30 minutes. That's what we're going to try to go for. The topic today is learning health systems and the pursuit of health equity. And, you know, the additional keyword that I could have tried to string into this title would have been social determinants of health, because that's where I'm going to focus the discussion today. Although I'll be really interested in the question and answer period if you all see parallels to other parts of what a health system does. Social determinants tends to be something that I just have a fair bit of familiarity and comfort in. So I wanted to focus some of the potential insights or learnings about learning health systems in that area. But again, I'm interested, and I genuinely don't know how generalizable some of these insights might be. So thinking about our time today, I thought I'd start by saying just a little bit, because I imagine many of you are familiar. You've got great folks doing work in social determinants at University of Michigan. I was thinking, especially as I was preparing these, like, oh, I wonder if Paula Lance will be there. She should just be giving this talk. But I'm going to say a bit about the growth of social determinants of health programs at or in health systems. And then I'm going to try and kind of go right at this debate that I think is totally legitimate about whether or not it is appropriate for health systems to be doing, quote unquote, social determinants of health. And I'll say more about why I think that is a really important and legitimate debate. Then the one kind of theoretical thing I want to introduce here comes from political philosophy and is a distinction between ideal and non-ideal theory. And I think I'm going to put it on the table and try and use that distinction to clarify some of what people seem to disagree about when someone says, yeah, totally legitimate for health systems to be doing social determinants of health, and another equally thoughtful and considerate person says, oh, totally not their lane, they should stay out entirely. I think ideal and non-ideal theory can help us make some headway on that. And then, of course, I want to spend the back half of this half hour really thinking about the implications for learning health systems. I should also say that I'm someone who, when I'm giving a talk, I think the onus is 100% on me to be as clear as I possibly can. And so if you as a listener are sitting there and saying, like, I just have no idea what she means by that term, or I just have no idea what she's talking about anymore, please just know that I feel very strongly that's my fault, not your fault. And so please do use the chat, and I will keep an eye on it. I can't watch it perfectly, but I will keep an eye. And if there start to be 2-3 comments that say, what do you mean by X? Or, you know, we've lost the thread, I will pause and I'll try and kind of retrace my steps to make sure that everyone is coming along lock in step.
And I'll also keep an eye out so I can interrupt.
Perfect. Jody, just fire away at me. You know, I will take zero offense and in fact welcome it. Okay, so I asked Jody and the crowd at the Collaboratory to send me some of the kind of foundational materials about how the University of Michigan thinks about learning health systems. And this was one of the kind of graphics that really spoke to me, because I thought, oh yeah, well, that makes good sense and kind of resonates with what I had previously understood about learning health systems. You know, it's essentially the idea of being in a continuous learning loop where you are performing action, kind of assembling or analyzing data to understand what your performance means, somehow interpreting those results, and then refining or you know, pivoting on whatever your intervention initially was. And the key is that this is a continuous loop rather than having one set of people implementing, another set of people measuring, and another set of people kind of doing the analysis, which might be the more standard way in which these processes unfold. So health problem of interest, I think the learning health system concept is quite well established. And in fact, one of my mentors, Elizabeth Bradley, had what I think is one of the most like kind of canonical learning health system success stories. And that was thinking about reducing door-to-balloon time for heart attacks, myocardial infarctions. This is the paper from 2006 in New England Journal that really laid out, after a series of both qualitative and quantitative investigations, what set those health systems apart that were really achieving very low door-to-balloon times, meaning they were getting someone from a heart attack in the field into an ambulance, to a hospital, seen, worked up, into a cath lab, and usually stented or ballooned in a fairly quick amount of time. And the key graphic, it's a wonderful paper. It's a great just story about how research changes the world. If you don't know it, I would really, really encourage it. They identified, I think initially it was 4, as you see here, and then maybe there were up to 6 key managerial strategies. And they were things like having the cath lab open 24/7, having this kind of person carry a beeper, like very practical, tactical workflow type things that really set apart those hospitals and health systems that were able to achieve fast door to balloon times versus slower door to balloon times. So you can see here one of the key figures. Again, there are many versions of this, but the number of strategies that a given hospital or health system had adopted, 0, 1, 2, 3, 4. The number of hospitals, so kind of the distribution over a bell curve of where hospitals lay on the adoption of strategies, and then the average of median door to balloon times. There we go. And you can see more strategies adopted by a health system, lower door to balloon time. The kind of research team here really then worked with health systems to do continuous monitoring and improvement of their door to balloon times, and just really moved the field. And by the field, I mean the field of practice, to bring down the standard door to balloon time by 25, 30, maybe it was 35 minutes over a series of 5 to 10 years, set up a big national door to balloon coalition, taught people how to implement these strategies, and really saved thousands and thousands of lives. And I've always looked at Betsy, who's a dear friend and mentor, and just thought, you know, like if you hung up your pen tomorrow, this has been an enormous contribution to the literature. So this is one of my favorite kind of learning health system stories. What I'm going to talk about today is some of what I think maybe the wrinkles are as we go from that really clean application of a learning health system concept to apply it to social determinants of health. So that's why this is the same graphic you saw 2 slides ago, and I've just kind of added social determinant here to frame what we're going to talk about here today. Why would thinking about learning health systems with regard to social determinants be valuable? Well, we're in a moment where tons of policy trends are kind of providing wind in the sails of those health systems that are willing to think about social determinants. And I should say, what are social determinants? By that, I really mean non-medical determinants of health. Things that are social in nature generally lie outside of the quality of care or the timely delivery of medical care, but that really influence people's health. So you could think about things like nutrition, housing status. You could think kind of way upstream on a social determinants of health framework. You could think about the amount of power or agency someone feels over their life. And so there's a lot to be said about distinctions among social determinants of health, but I think both at the federal level, when you think about how CMMI is doing accountable community of health work, et cetera, at the state level, where a number of Medicaid redesigns and Medicaid waivers are really emphasizing health systems involvement in social determinants of health, in some cases even making it a requirement to become a Medicaid accountable care plan or a Medicaid, sometimes they're called CCOs. You must show evidence that you're doing some kind of social determinant of health work. And then, of course, you could think in the philanthropy world, you know, that's its own special kind of policy, right? When RWJ turns its attention to something as a gorilla in the room and says, we're going to grant make around social determinants of health, it's influential on the field. And so I think you're seeing lots and lots of not just like federally qualified health centers and the kind of primary care oriented healthcare delivery organizations, but real like big health systems, Trinity Health, Catholic Health Initiatives, are really trying to put a lot of certainly attention and a fair bit of money around addressing social determinants of health amongst their patient populations. The first thing most health systems do, which is very much in keeping with the learning health system approach, is they have said, yeah, we're doing SDOH. Don't worry about it. We're screening. And you can just see if you're interested, Siren is a fabulous resource based out of UCSF, led by Laura Gottlieb and colleagues. They have arrayed, I think it's got to be 17, 20 different screening tools that a health system might choose to use to ask patients, pen and paper, on the phone, on an iPad, about their potential social determinants of health needs, if you will. It's generally not a very asset-based approach. It's generally asking questions like, have you over the last 30 days ever been in a position where you weren't sure where your next meal is going to come from? have you over the last X amount of time, not been sure where you were going to sleep the following night. And so this is how health systems are now taking in information about the potential social needs of a patient population. Some places will do it in a primary care setting. Some places will do it in an emergency department setting, but many health systems now beginning to try and be systematic in the collection of this information. And so I wanted to say just a touch, because I didn't want to assume anyone came with any background about the kinds of responses that health systems and hospitals are standing up once they're getting information fairly systematically about the social needs of their patients. The first, and I would say the biggest, by which I mean the most popular, the one for which there is probably the biggest and the strongest evidence base, is around food and trying to meet or shore up patients' reported lack of food or uncertainty about where a next meal was going to come from. And so you have things like on-site food pharmacies, meaning a hospital or health system will have on-premises a food pharmacy that looks like a food pantry, if you've ever been to one, usually stocked with food of a certain nutritional value. And the thought here is that it's a stronger referral link to go straight from seeing someone in an emergency department, for instance, them saying, look, I don't know where my next meal is going to come from. Maybe I'm diabetic. And so you could really imagine a direct correlation between a lack of food or a lack of nutritious food and their health status. And the idea is that someone on a clinical team, might be a physician, might be a nurse, might be a social worker, can say, look, right on premises, I can walk you there down the hall. You could go and see the food pharmacy. And it's certainly a short-term solution, right? Generally, people are only gathering as much food as they can carry, so a bag or two, but an intervention to try and tide people over for some amount of time. These have become popular. Geisinger has one. This particular picture is from a Nashville General Hospital food pharmacy, but there's been a fair bit of growth in this area. The other two kind of food interventions that have gained significant traction, I think, are health systems, usually contracting, but sometimes they'll stand up their own mobile markets and send kind of a fresh truck or a van stocked with fresh food out into a community that they think is a food desert or otherwise has access barriers to fresh and nutritious food. Or the other big one is home delivered and or medically tailored meals. This has been tried certainly in Boston, where it was really quite rigorously evaluated and published in Health Affairs back in 2018. And then I know, because I'm working with a group in Cleveland that's doing the same thing. So just to give you a flavor, when I say health systems are thinking about social determinants of health and are in some cases really trying to do stuff, meaning allocate staff, space, stuff, money towards addressing social determinants of health, this is kind of what I'm talking about. The second big kind of category, if you will, when you think about what health systems are doing in social determinants of health, is they're quote unquote getting into the housing business. So this is a piece on the left from Kaiser Health News in 2019. That's great and a fairly long read, kind of going through different ways in which hospitals and health systems have become engaged in the business of affordable housing, public housing, and trying to both place people in that housing, people who might have been chronically homeless or maybe even short-term homeless, and then provide supportive services to make sure that those folks are stable in that housing and are not winding up back couch surfing or unfortunately on the street. Just to give you a sense of like who's doing what, or to bring to reality kind of what is going on in the field. Boston has at least one hospital, probably more than that, that makes grants to homeless shelters within the city. And those grants are specifically for services that would go towards high cost, high need patients, meaning I at the hospital identify a list of my 100, 150 frequent flyers. I put that in quotes because it's not the best term, but I'm using it with a clinical audience who I imagine either uses it or at least knows it. And so I at the hospital provide that list to the shelter and I say, here's $100,000. If these people come to you, then you are to call this additional layer of case management or make sure they have a bed or make sure they get set up with the following services. And so you can see it's an additional layer of kind of services, supports in a really non-ideal setting, right? A homeless shelter is not generally where you think about doing really robust interventions, but an extra layer of support just for people who are pre-identified by the health system as high need, high cost. Why would the health system do this? Because generally for those high need, high cost folks, if you think you can stabilize some element of their life, housing would be a good one. The expectation is their healthcare costs are going to come down. And in Boston, we have very few uninsured people. Most of these folks are on Medicaid. If they're part of a Medicaid accountable care organization, then the health system's responsible for total cost of care. So now they've got incentive alignment to try and make sure that person's future healthcare costs are on a downward trajectory. How do you provide a list of high flyers without violating HIPAA? Good question, Rob. I just saw that. They set up BAAs. And so they go through the process, and it's been a long process trying to get homeless shelters to be kind of approved entities, but they have worked through that. And I watched it. It was long. The other things I just want to mention is there's also health systems that are trying to help cut through red tape, meaning kind of administrative burdens, to prioritize housing vouchers, which are generally like publicly issued to people who, again, are high need, high cost from a health system perspective. And then out in Portland, Oregon, there's actually a great piece in the New York Times now from a number of years ago, I bet it was 2016, about a series of Oregon hospitals collaborating to actually build new housing units. So 400 new housing units were built, in part because a number of health systems pooled their community benefit dollars and actually constructed new supply of housing, which is typically the thing that people in housing lament, is like, we're always rearranging deck chairs on the Titanic. What we really need is new supply of units. And in Portland, Oregon, you saw that coming from health systems. The last example would be workforce development. And I won't say much about this other than here's an example from West Virginia. It has also happened in Boston, where health systems put a fair bit of money to do usually training for people who don't have a college degree, but these are folks who would slot into like home health worker roles, sometimes community health worker roles, sometimes think like lab techs, radiology techs. And so in some cases, great. And in some cases, there is not a requirement that if you go into a health system funded workforce development program that you work for said health system, but in some cases there are. And so I just wanted to mention this as a third example of health systems getting into social determinants of health. So there's this big question, and like I previewed at the beginning, I think it's a totally legitimate question about, should hospitals be doing social determinants of health work at all? And I think there's a camp that says, look, absolutely. You know, we're here at Learning Health System event, and a lot of people would say, look, even if they don't have these skills now, like they're not food experts, health systems are really good at learning, and they're incredibly incentive responsive. And so if we can just figure out how to align the incentives so that it makes financial sense for them to do it, they will do it, and they'll learn how to do it pretty well. Other people will say, yeah, you know, we should let health systems do this because no one wants to see growing social service budget lines at the government level, because we're American and we hate the idea of a welfare state. But like, no one's going to notice an extra $100 grand, an extra $1 million, an extra couple $1 million in a health system budget or a healthcare budget. You know, we've been huge and bloated for a long time. And doing social services basically through the healthcare delivery system makes it much more politically palatable than trying to do it through government. And last, and I think most convincingly for me at least, is to say, like, there's moral urgency here. Like, we live in an incredibly wealthy country and people do not have food to eat. Legitimately. It's not a made up like, oh, I don't have the kind of ranch dressing that I want at home. It's like people, and a lot of kids, in fact, are hungry in this country. People and a lot of kids are, in fact, without housing, without safe, stable, affordable housing. And there's moral urgency to respond to that. And so look, if healthcare systems, for whatever reason, because it's incentive compatible or they think it's good press, whatever they want to do, if they're willing to get into that game, we should be grateful. There's another camp that says, absolutely not. Health systems should not be doing this whatsoever. You know, it's not where their expertise lies, and we should not have them be so, you know, arrogant as to think that they can just learn this on a whim. People in community-based organizations have been doing it for decades. Other people say they shouldn't be doing it because it's going to be so expensive. What do you know that healthcare does that is in any way affordable? Right? You send something through the healthcare system, it is going to become a bloated budget item because healthcare is just an incredibly complex set of systems. And then the third and maybe the most like conceptual critique of this would be, look, when you let healthcare build a food pantry on site, it gives healthcare a kind of power to kind of set the agenda about who gets in and who gets out, who's eligible for what level of services. And this is effectively a privatization of social services. And more specifically, and you've heard this already in what I said, it allows for healthcare to prioritize people who are kind of high cost to them, so they rise to the top of the list, over other people who might be otherwise like totally equally deserving. And so these are all reasons to say, like, no, healthcare should not be doing this at all. This is where I think ideal versus non-ideal theory can help us a little bit. And again, I won't bore you with too much kind of political philosophy or background, but essentially non-ideal theory is to say, like, look, we need to take the world as it is, blemishes and all, corruption and all. You know, sometimes it feels like the world's going to hell in a handbasket, and we need to just stare that straight in the face and be honest with ourselves that that is the world we live in. Non-ideal theory in a technical sense assumes partial compliance to rules and obligations, meaning it says, look, some people don't pay their taxes, and sometimes government is corrupt and doesn't deliver on the services and programs that it said it would. And sometimes businesses skirt the rules and don't fully comply with regulations. And that's all part of the picture of non-ideal, kind of a non-ideal view of the world. And the upside of thinking in a non-ideal way is that if you reason according to non-ideal theory, you typically come out with quite pragmatic solutions. The shadow side is that it can yield normative prescriptions about what we should do, what a health system should do, that I think can set back rather than advance really fulsome conceptions of equity. And I'll say more about that in a moment. Ideal theory, on the other hand, provides a view of how society ought to be and indicates the principles that have to be in place to try and achieve it. So when you think about philosophy, political philosophy, moral philosophy, typically they deal in ideal theory. And in fact, there's a book here behind me, The Tyranny of the Ideal, which is kind of philosophers saying, like, maybe we've gone overboard with this whole ideal theory thing. Like, we've been so conceptual that we have failed to deliver like pragmatic ideas about how to be just or how to be equitable. Again, in a technical sense, ideal theory assumes full compliance. So anyone who is quote unquote obligated to do something, or there are kind of rules and statutes, when you are reasoning in an ideal theory world, you say, like, look, people do what they're supposed to do. I think it's valuable because ideal theory helps us to clarify the desired end state when we think about, you know, what are we trying to achieve really with a health system or with a society? But the shadow side, of course, is that some find it too idealistic to be useful. Sometimes, just to bring this back to like real politic in the classic sense, I think, I almost put their heads here, I think of like a Hillary Clinton as a non-ideal theorist. Bernie Sanders, very ideal theorist. So you have a sense of kind of complements here. So to return and use the non-ideal ideal distinction in terms of this question, should health systems be doing social determinants of health? My take is, look, in an ideal world, I think few of us would really suggest health systems are the first best option for doing food, housing, workforce development. But in a non-ideal world, meaning we take the world as it is, community-based organizations are hugely under-resourced. Government generally does not have political support to expand welfare state offerings or social service offerings. And so we're a little boxed in here, like the cavalry is not coming. So who do we want to try and make even incremental progress on shoring up what many people think are basic human rights, food, housing, maybe a job? So in a non-ideal world, I think it's difficult to argue that health systems' efforts to respond to the moral urgencies of people's social needs is impermissible. And I think the real challenge and the really sophisticated question, you know, in the world according to Lauren, is trying to figure out how to get from a non-ideal world, to an ideal world. So if we're in non-ideal now, and ideal is what we're trying to achieve, like what is the way that I can behave now that's both responsive to what is, but sets the table to also help us take some steps towards that future ideal. So if we return here to think about the implications of that ideal, non-ideal distinction for learning health systems, specifically on social determinants of health problems, I think it creates some interesting, like I said, wrinkles or nuances specifically for these two stages of learning. It's specifically around the interpretation of results and then figuring out like what to do next, the design of the intervention. And let me just say a little bit more about that. So let's go back to the idea of an on-site food pantry at a hospital or a health system. I'm going to show you just like some very stylized performance data. And then we're going to think from there about if this was the data, how do we interpret that and what would we do next? So the columns here that I've set up are eligible patients screened. So that would be the question kind of being asked and answered in this column is, of the eligible patients that this health system has that they want to screen, how many of them have successfully been screened? The second column is, okay, of those screened, how many referrals have you made to the on-site food pantry? And then the third column is like, okay, they got to the food pantry, did they actually get services or food before they walked out? So you could think, again, totally stylized. Let's say there are 100 total patients in a high need, high cost pool that the health system has said, we want to really focus on their social determinants of health. We want to screen them. We want to get them services. So at T equals 1, meaning you're 1 month or 6 months into the program, you could say, look, 20 people of the 100 that are eligible have been screened. 5 of those have been referred. So 5 of 20 is that 0.25. And of the ones referred, 3 got services, starting point. Now we're going in the loop, learning, learning, learning. So we do some process refinement and we say, oh, we need a warmer handoff between the screening and the actual food pantry. So we make those changes. We're at T equals 2. So now we've got more people screened. A greater proportion of those screened are actually being referred, and a greater proportion of those referred are getting services. So we're headed in the right direction. Still, you could make refinements, you could improve the process, and now you're at T equals 3, and you can see, once again, there's improvements in all 3 of these columns. You could think about some, again, stylized, there's some asymptote that you're gonna reach on this, right? So if we had 100 patients who we wanted to potentially think of as eligible, at some point we might say, we screened all of them, 100 out of 100, 50 of those who we screened actually screened positive for some kind of food problem. And so they were referred to the food pantry, and everyone that we referred to the food pantry got services. So that's that 1.0 bottom right. And you can see here, there's like just monotonic directions, monotonic increases in these cases of improvement or learning. And I think that's totally in keeping if we go back to the kind of traditional, as I understand it, learning health system. That's what you see here too, monotonic direction of change. So here, the average door to balloon time kind of monotonically fell, and that was considered success. We have learned, we have improved performance. And I would say, plenty of people, especially those who really think in non-ideal terms, would look at this and say, that's a win, huge win, And the reasoning would be, look, a lot of people who would not have otherwise gotten food are receiving food through this program, this on-site food pharmacy. And we're meeting a basic human right, basic human need at the very least. So win, keep on learning, just like this. The other folks who take a more ideal view of the world would say, this is a loss, big problem, health system just getting in the way. The health systems are now getting to determine who's deserving of food, but their view of who's deserving / eligible is really way too narrow compared to other food-focused organizations. So you can see the comparison here is the important thing. People who say this is a loss are comparing what the health system is doing to an idealized state where food-focused organizations had more capacity to be reaching these very patients. The ideal folks are saying, look, this is a win because people are getting screened who otherwise would get nothing. That's the comparison state. And that's how we wind up with 2 very different assessments of the equity kind of implications of this program. Someone looking from a non-ideal world would say, this is equity enhancing. Someone looking from an ideal view of the world might say, this is equity diminishing. So I just want to say a bit about maybe how to reconcile, or maybe not reconcile, but at least kind of combine or amalgamate these ideas of the non-ideal and the ideal. And I think what I'd like to propose is something like, look, when you're leading or you're working in a learning health system, I think we need to take a kind of bifocal view of performance. And bifocal is, I don't know a lot about this, but at least the very basic is that it's a lens that enables someone to see both near and far at the same, maybe not at the same time, but in the same lens. And it depends on where someone's kind of focusing their pupil or eyesight. If you're looking here through the green zone, you're reading, you're at the restaurant and figuring out what's on the appetizer list. If you're looking through the blue zone, you're seeing kind of who's coming down the road at you. And so I think the bifocal concept works for someone who's leading a learning health system in the sense that I'd like to ask them to both be thinking about, sorry, just telling me that I'm over time, and that's okay, I'm close. Someone who's leading a learning health system both needs to be able to look at the world as it is, meaning reason in non-ideal terms, and be able to pick up their gaze and look through that blue portion and say, okay, but also way out on the horizon, how do I think my behavior or the learning health system's behavior is potentially furthering the goals of reaching that idealized world or achieving the world as it should be? And I wanted to just say a little bit about the pragmatics of this. If we think about, again, assessing performance in any given learning activity, and again, we can go back just to the performance of that screen, refer, deliver food at an on-site food pharmacy. Here, you've just got a very simple x-axis that's time, right? T1, T2, T3. You've got a y-axis that's about provision of social services. And I've just used the numbers from that little stylized graph, right? T equals 1, we delivered food to 3 people. T equals 2, we delivered food to 8 people, et cetera, et cetera. And I think typically, if you were a learning health system and you kind of learned this way, I said 50 was kind of the asymptote, like everyone who got referred to the on-site food pharmacy also got food to take home with them. You might say, look, you know, we have learned. And so I said here, if you only think about the world as it is, you would kind of set it and forget it at this point. As much as I think learning health system folks like to think it's never ending, it's continuous. Like the realities of health systems are people have limited attention and they focus on this for a little bit, and then they think they solve that problem and they go to the next thing. And so that's what I mean by at some point you'd reach an asymptote, you'd say, we screened and referred everyone who needed it. And we can kind of turn certainly our like best analytic minds to something else because we have learned how to do this successfully. And what I'd like to say is like, well, maybe that's only the first half of a really robust and principled strategy around social determinants of health that is responsive to the demands of equity. So I said here, you know, performance should be judged maybe against non-ideal benchmarks early in the strategy. That's what we just saw. You reach the asymptote and you say, I've done it. But then also maybe some ideal benchmarks later in the strategy. So what would that look like? Again, this is incredibly stylized, but I'm thinking, if you think again in time on the x-axis and provision of social services on the y-axis, when we think about kind of what it means to learn well, or Jody said in the introduction, learning health systems are about building better health systems. And we ask ourselves, what does better look like? I think the first part of a really principled SDOH strategy is thinking in non-ideal terms and saying like, we got to provide more food. We got to provide more opportunities, more workforce placement opportunities or seats in that class. And so you're thinking about a health system that is growing its involvement. So providing more and more over time, doing the process refinements and improvements. But then you get to this kind of blue zone. And I think we have to be also thinking about health systems' role in bringing that more ideal, just, equitable world into being. And there, I think, you know, you want a health system that's diminishing its role intentionally over time. And again, I've chosen really intentionally abstract labels for this x-axis, because I don't know if the right time horizon here is 5 years. You know, you're growing it for 2.5 and then you're diminishing it for 2.5. Or the right time horizon here is 10 years. You know, each green and blue are 5-year periods, or it's 20 years. I don't know the right answer to that question, but I know that conceptually, it feels appropriate to me for health systems both to be growing their role in the near term, responding to the moral urgency of now, but also having a plan to kind of get out of the way and let other people who don't have quite as perverted an incentive scheme to kind of take over and really fill the void of providing a social safety net in the United States. So the idea here is that, you know, what you're seeing is health systems line of social determinants of health provision. And the reason that I think it's appropriate for them to diminish their role in the blue portion is because ideally you want non-health system actors, and forgive me for the crinkliness of this line, I drew it by hand, but you want non-health system actors coming in to really be the primary providers of food and housing and workforce training, because as the critics say, it's not what health systems are really designed to do or are necessarily best at. Okay, the last point I want to make is just that knowing when to shift lenses, meaning to take your eye from that kind of near view to the far view, is, I think, a really complicated and nuanced judgment call for health system leadership. So at some point, you know, you've got to, there's no atlas to tell you, okay, this moment, January 17th, 2027, is when you should shift your gaze and you should start trying to get out rather than get in. But again, conceptually, I think it's got to be there. And really what this is a change in the interpretive frame. So if we go back to the learning health system scheme that analyze results, you can only really analyze and interpret results with regard to some baseline or benchmark. And I think it's here that that interpretive frame has to shift. And as a result, the ensuing strategy would shift. But other than saying it exists, it's a point in this proposed framework, I think all I can say is, God bless you and good luck. You know, if you're in that health system leadership spot, maybe I could say a little bit more, but I just want to acknowledge, I think it's a really hard issue. Some of the kind of iconography around learning health systems gestures towards this in the sense that it says, look, you've got to take external evidence into account when you're doing your own performance results interpretation. And I think that's absolutely right. But I think it's more than just external evidence. I think we also need to be thinking about a role for kind of moral imagination in the interpretation of performance results. And what do I mean by moral imagination? This comes straight out of my divinity school's training, but it's essentially the ability to envision the full range of possibilities in a particular situation in order to solve an ethical challenge. So it's moral imagination is saying, like, look, we don't only need to look at the world as it is. We can imagine a better world, a more equitable world, and we can use that as kind of a piece of or a framework for the interpretation of our own performance results. So last slide here, the recap. One is, I just want to, again, acknowledge that the question of whether or not hospitals should be doing social determinants of health is, I think, quite reasonably contested. And I myself feel often, you know, Monday, Wednesday, Friday, I vote yes, and Tuesday, Thursday, Saturday, I vote no, and I go to church on Sunday. But I think separating out the idea of ideal and non-ideal circumstances can facilitate some convergence among thoughtful people, where at the moment, one side is just saying, yes, they should, and the other is saying, no, they shouldn't. The second kind of takeaway maybe is that normative questions are, I think, really tightly bound up with the real world practice of being in a learning health system. And that's because you have to know what it means to be learned. You know, if we're engaged in the process of learning, that suggests a process. And while we can be forever engaged in a process, usually we want some sense of direction about where that process is heading. And so the concept of what would it look like to be learned is open. And I have proposed here that what it looks like to be learned kind of in the first half of a strategy might be different than what it looks like to be learned in the back half of a social determinants of health strategy. And then finally, you know, taking a bifocal approach to learning, where you both focus on improving performance in the world as it is, and thinking about how your performance may be influencing or making space for others in the world as it could be, may enable more principled strategizing regarding health equity. Thanks so much. And I said here, fire away. So Jody, jump in here. And then I'm really eager to look through this chat and the Q&A function as well. Thanks very much.
Thank you. That was great. And we can probably turn off the screen. Yeah, so I'll just start with, there's a bunch of questions. I'll start with other people's questions. And I'll also reiterate something that you said when we were planning, that if we don't get to all the questions, we'll figure out a way to communicate them in another way. So I'll start at the beginning maybe. So Melanie started with a question around food, and it's, I think, related to some of the outcomes and some of the things we were talking at the end, but she asked whether food, so she said food insecurity is an income issue. Are you aware of other projects, LHS or health system projects focusing on income as a social determinant of health?
I've not heard. It's funny because, of course, in the like global health world, cash transfers are a big thing. And the big debate is conditional cash transfers versus unconditional cash transfers. I've not heard of anything like that in the domestic kind of health system sphere. Yeah, I think the closest that health systems get is this workforce development concept, which is their way of thinking about how to get people additional financial resources.
Mm-hmm.
Jody, do you know of any?
No, I mean, I can kind of imagine maybe why they wouldn't necessarily, like it tends to be trickier to try to negotiate giving people money than giving people what we think they should be spending money on.
Yeah.
But yeah.
I don't know.
Yeah. So somebody else asked whether partnerships with existing food pantries would work as well without having the food pantry set up in the hospital. So the partnership model.
Yeah. So that's the other dominant model, you know, in social determinants of health world, one of the big catchphrases is, are you building it or buying it? And so buying it is the strategy where you contract with an existing community-based organization and you make them a grant, or you sign a contract and you deliver them services, sometimes with particular strings attached, like I'm going to give you this grant, but as I said about the homeless shelter, this money is only to be used on referrals coming from our health system. And other times it's more carte blanche. Here's $100,000 and you can use it kind of for general operating expenses. So that's the buy it strategy. The build it strategy is more what I was focusing on here, where health systems are in some ways creating new supply or creating new social service capacity in the system writ large by opening up their own food pharmacies or mobile vans or workforce training. And I would say the buy it strategy is in some ways less controversial because people say, well, at least you're supporting the people who have the expertise rather than you trying to develop this expertise on the fly. But I'll tell you, it's still not without controversy because, you know, I wrote a paper on this that came out in Milbank Quarterly in 2020 or 2021. The impact of health systems becoming funders or a source of revenue for community-based organizations is non-trivial on the community-based organization ecosystem, because once, you know, I hear at my food pantry that Jody at her food pantry has money from Mass General Brigham, I say, what's Jody doing that she's got money from Mass General Brigham? Oh, she brought a nurse onto her board. I should bring a nurse onto my board. And the kind of what sociologists would call the institutionalizing pressures of that turn out to be quite stark, quite fast. And so the paper in Milbank Quarterly, it's called Money Moves the Mayor, is trying to document the way in which even a whiff of health system funding for community-based organizations who are themselves very financially fragile creatures generally, tends to really stand to, some would say distort. If Paula Lance were here, she would say medicalize. Other people would say professionalize, but really change what community-based organizations look like and potentially how they operate.
Yeah, that's, I mean, there's a few people that have sort of put some comments to that, like sort of what you're describing up there now. So, yeah, I think, are there, Mary asked a question about whether there's a best practice for how and when to collect social determinants of health data, or is that just part of the process? Like, is that?
Yeah, so I don't know if there's clear best practices yet, but there's certainly been papers out there. And again, I think Siren, this UCSF group that's run by Laura Gottlieb, have themselves done a lot of the best research on this. And they have a research library that also kind of pulls together a lot, is an excellent resource on questions like when and where and who should do SDOH screening. I will say, like I said, the most common places to do it are in emergency departments, in primary care, and sometimes in Medicaid managed care or Medicaid accountable care organizations. They'll have someone from kind of member services call and do it over the phone. There has been some debate about whether or not people feel comfortable with a clinical team member asking potentially very sensitive questions about housing status, domestic abuse, things like that. And I think there's been some research asking people who are either uninsured or on Medicaid, how do you feel about being asked those kinds of questions? Some of this was done by Elena Byhoff, a colleague of mine. And I think the literature is a little bit mixed, but maybe leaning towards, I was happy someone asked, and I felt kind of seen and validated. And I think it might be relevant for like the care plan if I tell you I don't have a refrigerator to put my insulin in. So I'm glad someone asked and I was willing to share that information. Certainly, I think what's interesting is I think sometimes clinical teams are themselves uncomfortable asking the question. And so that can come out as like, oh, well, we don't think patients want to be asked because it would be very embarrassing for them. And it's like, whose discomfort are you really are really concerned about? But that's an editorial comment. But there has been research on it, and you could go find it in the Siren Resource Library.
Okay. So a follow-up to that from page 9, maybe some question just jumped on my screen, but it's related. So how do we better account for the structural and environmental aspects of SDOH rather than only focusing on the individualized data collection? I think the Siren database is mostly around the individualized data collection aspects of this, right?
Yeah. I mean, in order to like really think more structurally about social determinants, I think you've got to take it out of health systems' hands. Like, I just don't think health systems are geared to do that. They're geared to think at an individual level because that's what patients are to them. That is just like the natural unit of analysis. So you either got to do like a lot of reframing, retraining to get the right people in the right spots. And let me tell you, they're probably not the community benefit officers, but like get them in the right spots at a health system where they can really change the strategy. But even then, I think the incentive schemes that are kind of bearing down on health systems are still quite like, what proportion of patients have you done XYZ to? And so if that's the incentive scheme, I think they're going to stay very kind of individual social needs focused. So my short answer, Paige, and I'd be interested in what you think, but is like, if you really want a structural approach to social determinants of health, you got to get this like out to community-based organizations and back to government, really, who are more oriented towards like population, community structures to begin with. I'm not super optimistic about retraining health systems in that way.
Mm-hmm.
I wish I were more so.
It's I don't know, that's the, I don't know, $4 trillion question or answer, right? Because it's almost that, I mean, ideally, if we're talking about ideal worlds, right? It's the third level of the lens almost, right? You've got your bifocals, but then looking across, like really across the whole structure of our society.
Yeah.
We'll solve that problem too.
I guess we should give credit. Some of the anchor institutions, I think, are trying to be much more like take the community as a unit of analysis and think about their impact on a community writ large, rather than thinking about their impact on a patient panel or a specific like set of high need, high cost organizations. So I think maybe they're the bright spot in the health system universe for thinking structurally.
Yeah. I had a thought, but I forgot what it was. So we should both be sort of looking through the comments because they keep coming in and they're really thoughtful. And I don't know if you have just some general.
Yeah. Let's see.
Just a question.
I'm reading Patricia's nice comment.
Nick has a question and I'm not sure I completely understand it. So I'm going to try to guess, but the question is, what are the ideal and non-ideal circumstances of learning health systems? So maybe, I mean, we're, over here in a Department of Learning Health Sciences, all of us are engaged in sort of in this sort of believe in the vision of a learning health system. And so for us as a community, what are our sort of ideal and non-ideal? What does our ideal and non-ideal lens look like?
Yeah, I mean, I think theorizing about learning health systems in a non-ideal world says, look, like you guys are going to do your thing because you're learning health system people, but like, not everyone's going to collect data the way you want it to collect it, and not everyone's going to analyze it the way you want. And so there's going to be kind of leakage at every point on that sphere. And so I think that's the non-ideal version of learning health systems, whereas the ideal is really assumes full compliance. That's the short answer. I guess another question would be, you know, my talk in some ways has put forward a non-ideal and an ideal version of learning health sciences or a learning health system that says, in a non-ideal world, you've got learning health systems that are kind of just very head down, like looking at the performance data and assuming that to learn is to achieve some kind of monotonic increase, decrease, whatever it is, but that learning is unidirectional, whichever direction it is. And I've tried to say, look, I think that's not ideal, because sometimes we need to be picking our heads up and thinking about performance, not only head down kind of spreadsheets and graphs, but also in relation to an external environment. And so performance at one point could and should maybe be monotonically increasing, and at some later point, it should be decreasing. So that's what I'm proposing, is kind of a more ideal conceptualization of a learning health system. It's a little bit of a fudged ideal, non-ideal distinction, but I think that's one way to think about it.
Thanks. And I think that's a nice way to sort of wrap up where we are. And I think, you know, you've given us a really nice framework for thinking about where we are and where we need to go. So just thank you. I won't put up the last slide that I have, but there will be a survey going out. Thank you, Lisa. Respond to it, and we'll see you in September for a poster session showcasing the LHS work at the University of Michigan. So thank you so much. And thank you, Lauren. And next time we'll do it in person.
Absolutely. Thanks, Jody. Thanks, everybody.